Good evening, one and all. I'm Dr. Srinivas Kudva. Firstly, I'd like to thank all my teachers and my parents because of whom I'm here. I'm here to talk to you all about a small aortic annulus. Now, the issue with this is a small aortic annulus is actually a complex crown-shaped three-dimensional structure. There is no clear consensus as to what constitutes a small aortic annulus. In a surgical series, the annulus that would not accommodate anything more than 21 mm was said to be a small aortic annulus, or an aortic annulus less than 23 mm, either on echo or intra-op, was proposed as a small aortic annulus. So what you need to realize is this annulus is actually three different kinds of annulus. One is the virtual basal ring. One, what we have is the anatomic ventriculo-arterial ring here, aortic ring, and the sinotubular junction here. So these three rings, the three crowns, basically form the annulus. Now, how prevalent is this problem? Almost 17% in patients in the US who have mild to moderate aortic stenosis, 22 to 32% in Europe, and 34 to 46% in Asians. So this is much, much more common here. So how do we evaluate them? A 3D TEE is something which is non-invasive and easily done. An MD-CT or a multi-detector CT slice or a cardiac MRI. Well, all of this have little impact if there is a surgical procedure because most of the aortic annulus are measured with dilators there. So we have something which is the pressure recovery phenomenon, which is very, very important when it comes to small aortic annulus. What happens is just after the valve where the blood rushes because of the fluid hemodynamics, there is a pressure drop, and 2 to 3 centimeters ahead, there is again an increase in pressure. So this pressure recovery gradient is something which is important when it comes to a small aortic annulus as compared to a normal aortic annulus. What you need to realize is when it comes to echocardiography and cath, the echo has a higher gradient, valve areas can also be lower, and hence pressure recovery for the adjustment of the valve area is very, very important. The most common complication when it comes to a small aortic annulus is a patient prosthesis mismatch. Now, if the effective orifice area as compared to the body surface area is less than 0.8, if it is 0.65 to 0.85, it is a moderate patient prosthesis mismatch. Less than 0.65 is severe. Now, you need to realize that patients who undergo a surgical repair are more prone to patient prosthesis mismatch, especially because a smaller valve is used. So a lot of surgeons don't actually do an aortic root enlargement, and that is where the issue occurs. When it comes to the hemodynamics, the incidence of patient prosthesis mismatch in mild to moderate is still there. It ranges from 45 to 93%, and the severe actually ranges from 4 to 22%. So there is a large variability, especially when it comes to the hemodynamics between an intraannular and a supraannular valve. So that is how, even when it comes to TAVR, we will discuss this as to which is better. Supraannular valves do have better valve hemodynamics. So the hemodynamic profile is much, much superior when it comes to TAVI and patient prosthesis mismatch. This was deduced by Clavel et al. Oversizing of the valves, we do give a better, bigger valve when it comes to a supraannular valve. There is an absence of a sewing ring. There are lower gradients, less ppm, and a higher indexed effective orifice area. So women are more common when they have this small aortic annulus. They have a smaller BMI, lower surgical risk scores, less requirement for post-dilation, less ppm as compared to men, and better outcomes. So this is what is it when it comes to women and the short aortic annulus. But you need to realize that there are higher coronary obstruction rates, oversizing, and annular rupture. So when it comes to self-expanding valves versus balloon expandable valves, yes, the supraannular does have better hemodynamic profile. They have lower peak gradients, and there is no difference when it comes to the severity of patient prosthesis mismatch. This was by a comparative study done by Wegner et al. In the France registry, what they found, this was a study done between Evolute Pro R and the Sapien 3. They found that the mean gradient was a little lower with Evolute Pro R. The indexed effective orifice area was a little higher, and there was lower moderate to severe ppm. But again, the limitations of the study was it was retrospective. There were multiple imputations, and 5% of the data was missing. So basically, when you have a patient with symptomatic severe aortic stenosis, you need to realize you have to follow the algorithm. Now, guidelines are there, but yes, the patient has to be tailor-made, and this is where a heart team approach helps. So you need to have a cardiologist, a cardiothoracic surgeon, and an anesthesiologist, a physician, all of them get on board for this. When a smaller aortic annulus is confirmed, you risk stratify them properly, whether they are low risk, intermediate, high risk, and then accordingly, if they are low risk and if they have a longer lifespan than SAVR, intermediate risk, then you have to consider what other risks are there. High risk, yes, TAVR is hands down the best. So thank you for patiently listening to me.